Dr. Aureliano Moreno Andrade demonstrates an open globe closure and vitrectomy performed in one surgical setting for traumatic retinal detachment. And we want to thank Dr. Moreno Andrade for sharing this case. This is a patient with an open globe injury, baseline visual acuity between hand motions and light perception, a dense vitreous hemorrhage, and a retinal detachment. And as many of you know from the ocular trauma score, this eye carries with it a relatively poor visual prognosis. Now, Dr. Andrade is performing a 360-degree conjunctival peristomy to perform a globe exploration. He's looped each of the rectus muscles, and you can see that there's an open globe site just posterior to the rectus muscles. This looks to be a ruptured globe. And you can see here any prolapsed vitreous he's removing using the vitreous cutter. And this is a much preferred technique compared to, for example, performing a Wexel vitrectomy. Now, to gain access to the full extent of this rupture site, it looks like Dr. Andrade is now taking down the lateral rectus muscle, which is a really good idea to gain good exposure. It's going to help to decrease the amount of tension, the amount of manipulation of the globe in order to get good visualization. That's going to help decrease any risk for further uveal or vitreous prolapse. Now, using simple interrupted sutures to close this wound, starting centrally and working out in both directions towards the lateral aspects of the ruptured globe site. Looks like in this case he's using a vicryl suture, which is a braided suture. My general preference is to use a monofilament suture just to decrease the risk of dragging any uveal tissue or vitreous, but that's based on surgeon preference. Now he's switching over to performing the vitrectomy, and you can see that there's a 6mm infusion cannula that's been placed in the anterior chamber. And I think the reason that he's chosen to place that infusion line in the anterior chamber is to pressurize the globe. He's then checking the rupture site to make sure that it's watertight. And then once the other two trocars are in, the infusion line is then replaced into the inferotemporal quadrant where it normally would be. And again, this is a 6mm infusion cannula, which is a good idea to use in cases of trauma, since you want to make sure that the infusion cannula is fully within the vitreous cavity and not potentially infusing in the suprachoroidal space. Now, it looks like a lensectomy and I believe a capsule removal has been performed, and now he's moving on to the vitrectomy. And you can see here one of the complicating factors that often arises in traumatic retinal detachments is just the disorganization of the anatomy. There's quite a bit of blood here. It's hard to tell what's what. And this membrane here, is that retina or is that vitreous? Well, if you look carefully, you'll see that there aren't any vessels. And so that is a good sign that he's engaging the posterior cortical vitreous here. And again, moving very slowly, this is important to make sure that one is in the right anatomic plane and not potentially engaging retina, trimming the vitreous peripherally. Now he has a better view. And it looks like just inferior to the optic nerve, infranasal to the optic nerve, there's a little break there. And so he's going to apply some endolaser. The fact that the endolaser is taking indicates that that break is in attached retina. Now looking at where the retina appears to be sort of streaming into the area of the globe rupture, checking peripherally just to make sure that there aren't any other retinal breaks. And now Dr. Andrade is putting down some perfluorocarbon liquid in the posterior segment to flatten the retina, also to provide some stability posteriorly as he's working peripherally. And in these cases where there's incarceration of the vitreous and retina in the open globe site, a limited retinectomy often needs to be performed. It looks like he's done that in this case and now is barricading this limited retinectomy with laser. That laser is going to be carried around, should be carried around up to the ora serrata, and multiple rows are a good idea. One can also consider doing 360-degree laser in this case. Obviously, a scleral buckle was not performed, and so that can give a little bit more support to the vitreous space in case there are any other peripheral retinal breaks that develop. Here he's done an air fluid exchange and now putting in silicone oil. You can see that the retina looks like it's nicely flat under air and under silicone oil. An inferior PI is created. This patient is aphakic, so that's going to help decrease the risk of pupillary block. And then the lateral rectus is brought back to its normal position, and the conjunctiva is closed. That's very nice, bringing the conjunctiva back to its normal anatomic position. So here's a picture of the patient. This is an external photograph that was taken of the patient. Post-operatively, you can see that PI is patent. The eye is aphakic, but silicone oil filled. And here is a picture of the patient's fundus. Post-operatively, you can see that sheen indicating that there's still oil inside of the eye. You can see the photocoagulation just inferior to the optic nerve, and then you can see those multiple rows of laser that are going towards the equator temporally and then down inferiorly. If you look back at the video, you'll see that there was also some 360-degree laser that was put closer to the vitreous base on the nasal aspects of the retina. Here's the patient's postoperative OCT. You can see very nice macular anatomy given the degree of trauma here. Maybe a little bit of parafoveal ellipsoid zone disruption there, but overall looking really nice, and a best corrected visual acuity of 20/50, which here you can see the estimated vision based on the baseline OATS score. The baseline score for this patient was somewhere between 0 and 44, and so the likelihood of getting a postoperative visual acuity of anywhere between 2200 and 2050 is only 2%. So this is really a very remarkable postoperative outcome in a patient who's undergone an early vitrectomy, so vitrectomy done in a single surgical setting along with an open globe repair. So here are some points I think to consider. I think there's a lot to discuss in cases of traumatic retinal detachment. It's really a beautiful case by Dr. Moreno-Andrade. But really I think the key issue here is whether these types of cases should be performed as a single surgery at the same time as open globe repair, or staged, meaning that the open globe repair is performed first and then at a later time a vitrectomy is performed. And there are arguments to be made for both of these approaches. For the single surgery approach, it really requires there to be a good view. And so this patient had a zone 3 rupture. You could see that the cornea was quite clear and the visual axis was clear. And so that certainly makes performing a vitrectomy in this acute setting more possible. You also want to confirm that there is a watertight closure, because if the wound is not watertight, for example, a very posterior extending wound that can't be adequately closed, this would be a very unstable situation in which to do a vitrectomy. And you saw in this case, Dr. Andrade actually pressurized the globe by putting the trocar in the anterior chamber and then went back to the wound to check it to make sure that it was in fact watertight. And certainly in performing both a vitrectomy and an open globe repair is typically done in patients who have an intraocular foreign body. The traditional thought is to try to remove the intraocular foreign body right away to decrease the risk of endophthalmitis. But generally speaking, traumatic retinal detachments and vitreous hemorrhages alone are usually performed in a staged manner. But you might want to consider doing the surgery in a single setting if, for example, you're worried based on the patient's insurance status or maybe their socioeconomic status that they may not be able to get that second surgery in a timely manner. You may want to consider doing this all in one setting. Also, trauma doesn't happen in a vacuum. Patient may have other serious medical issues going on related to trauma, whether that be neurologic trauma or other issues that may preclude the patient from being able to come back in a timely fashion for surgery. And so a surgeon may consider doing everything in one setting just for fear that they might not be able to come back to the operating room anytime soon. But generally speaking, I think most surgeons prefer a staged approach, and the reason for this is that it gives the eye a little bit of time to stabilize. If there's inflammation, for that inflammation to be decreased either just with time or with the use of steroid medications, and it allows the surgeon to better understand the underlying anatomy. In this particular case, there's no direct visualization of the retina due to the presence of a vitreous hemorrhage. And in an open globe case, in a trauma case, one could perform a very gentle B-scan, but you will have to be very, very gentle with the ultrasound so as to not put pressure on the eye and then potentially cause more expulsion of intraocular contents. Now, after the open globe injury has been repaired and the eye has been pressurized, an ultrasound could be performed intraoperatively, but that may not always be available. So in a staged approach, it gives the surgeon the ability to perform a proper B-scan and really understand the underlying anatomy, whether there's a choroidal hemorrhage, retinal detachment, or other pathology that needs to be accounted for when performing the vitrectomy. The other benefit of doing it as a stage setting is that the surgery tends to be more in a controlled setting. For trauma cases, sometimes these cases are happening after hours or with a surgical team that may not be as familiar with ophthalmic surgery as a dedicated eye surgery team. And so it gives the surgeon, in a staged fashion, it gives the surgeon the opportunity to be able to do these complex retinal detachment repairs at a normal operating hours with the normal team in an effort to try to give the patient the best possible outcome. Again, the other advantage here is that with some time, that open globe wound may have more time to heal, and so the globe is more likely to be watertight and therefore more stable for vitrectomy. Other arguments for performing the surgery as a stage procedure is that it does potentially give the eye some time to form a PVD. Traumatic open globe injuries tend to happen in younger patients, and the patient may not have a PVD. As you saw in this case, it didn't look like the PVD was up and it had to be induced surgically. And giving the eye some time between the open globe repair and the vitrectomy gives some time for a spontaneous PVD to occur, which can make the surgery a little bit easier. And then finally, if there are choroidals, it does give some time for those choroidals to liquefy, which can then be drained prior to the vitrectomy. Now, considerations for both of these approaches include inflammation and PVR risk. For people who advocate for early vitrectomy or even vitrectomy in the same setting as an open globe injury, the idea here is that by intervening at an early stage, one may be able to decrease the inflammation more rapidly and may be able to, by removing the vitreous, maybe decreasing the scaffold upon which PVR can form, because PVR can form quite rapidly in the setting of trauma. But the counterpoint to that for a staged approach is that steroids can be given and that can decrease inflammation, so that might decrease the risk for PVR. So there are arguments to be made both sides. Regardless of whether the surgery is performed in a single setting or in a stage setting, one must remember that traumatic retinal detachments are at a high risk for proliferative vitreoretinopathy. And you can consider, in addition to performing a very thorough vitrectomy, you can consider performing a scleral buckle, and you can consider performing both a lensectomy and capsule removal. The lensectomy and capsule removal helps to decrease the framework upon which anterior PVR may form. That could result in anterior vitreous-based contraction and hypotony. The use of a buckle is a little bit of a point of debate, and especially in eyes where, as in this case, the muscle, the lateral rectus muscle had to be taken down and put back on, where there may be some scarring around that muscle. Placement of a scleral buckle may be more challenging, and so the surgeon will have to decide whether or not placement of a buckle, the benefit outweighs the risks. We want to thank again Dr. Moreno-Andrade for sharing this case. It's a great topic for discussion and really a beautiful surgical outcome in an eye that had a very poor prognosis at baseline. Thanks so much. If you enjoyed this video, please visit us at Retinal.